Nursing care patients with urinary tract disorders. Micturition, voiding, urination all refer to the process of emptying the urinary bladder. Urine collects in the bladder until pressure stimulates special sensory nerve endings in the bladder wall called stretch receptors. This occurs when the adult bladder contains between 250 to 500 mL of urine. The nocturnal enuresis can be divided into primary enuresis, which is when a child has never achieved nighttime urinary control, secondary enuresis, related to another physical problem and resolves when the cause is eliminated, the causes such as stress or illness. Elders, the excretory function of the kidney diminishes with age, but not less than normal unless a disease is occurring. With age, the number of functioning nephrons decreases to some degree, impairing the kidney's filtering abilities. Bladder muscle tone diminishes, causing increased frequency of urination and nocturia, which is awakening to urinate at night. Diminished bladder muscle tone and contractibility may lead to residual urine in the bladder after voiding, increasing the risk of bacterial growth and infection. As we age, urinary retention, frequency, urgency, and nocturia does become more common. Urinary incontinence is not a normal outcome of aging. However, as we age, larger amounts of residual urine is left in our bladder after voiding. Oliguria is low urine output, usually less than 400 mL a day or 30 mL an hour for an adult. Anuria refers to lack of urine production, causes like lack of fluid intake, impaired blood flow to the kidneys. Dysuria is painful urination. Hematuria is the presence of blood in the urine. Polyuria is used to describe high-volume urine output. A urinary tract infection is an infection that begins in the urinary system. The urinary system is composed of the kidneys, ureters, bladder, and urethra. Any part of the urinary system can become infected, but most infections involve the lower urinary tract, the bladder, and the urethra. Women are at a greater risk of developing a urinary tract infection than are men, and an infection limited to the bladder can be painful and annoying. However, serious consequences can occur if a urinary tract infection spreads to the kidneys. Antibiotics are the typical treatment for a urinary tract infection. When treated promptly and properly, urinary tract infections rarely lead to complications, but left untreated can become something more serious than merely a set of uncomfortable symptoms. Untreated urinary tract infections can lead to acute or chronic kidney infections like pyelonephritis, which could permanently damage the kidneys. Infection of the bladder, cystitis, is usually caused by E. coli, a species of bacteria commonly found in the gastrointestinal tract. Sexual intercourse may lead to cystitis, but don't have to be sexually active to develop it. All women are susceptible to cystitis because of their anatomy, specifically the close proximity of the urethra to the anus and the short distance from the urethra opening to the bladder. Cystitis symptoms may include frequency, but would be coupled with burning, pain during urination, and hematuria. Infection of the urethra, urethritis, can occur when gastrointestinal bacteria spread from the anus to the urethra. In addition, because of the female urethra's proximity to the vagina, sexually transmitted diseases such as herpes, gonorrhea, and chlamydia also are possible because of urethritis. Renal calculi would likely cause flank pain. Bladder cancer symptoms would include hematuria. Urinary tract infections should be instructed to avoid caffeine, citrus juices, artificial sweeteners, as these substances irritate the bladder and can increase urgency and spasms. Intermittent catheterization carries a lower risk of infection than an indwelling catheter and is preferred for patients who are unable to empty their bladder by voiding. The Crede method, applying pressure to the suprapubic region with the fingers of one or both hands, is manual pressure on the abdomen, and the Valsalva maneuver, which is bearing down while holding one's breath, promote bladder emptying for a patient with a spastic or flaccid bladder. Timed intervals to take patient to void would not be affected if they are not able to empty their bladder by voluntarily voiding. The urine would remain in the bladder and be a site for infections to develop. A post-voiding residual urine test is done to evaluate the bladder's ability to empty urine. After a patient urinates, do a straight catheterization to check and see how much urine is left in the bladder after the patient voids. A urine output baseline would best be measured by a 24-hour urine collection. Some patients may experience a vasovagal response and become pale, sweaty, and hypotensive if the bladder is rapidly drained. The vasovagal response is not to be an expected response in each patient during catheterization. The nurse should be aware that it is a possible response in some patients and be able to recognize and respond to it. Draining urine in 500 ml increments and clamping the catheter for 5 to 10 minutes between increments may prevent this response. The best way to assess for a distended bladder in either male or female patients is to check for a rounded swelling above the pubis. The swelling represents the distended bladder rising above the pubis into the abdominal cavity. Rapid emptying of an overdistended bladder may cause hypotension and shock due to the sudden change of pressure within the abdominal viscera. Altering the pH of the urine, use of anticholinergics, or restricting fluids would not assist the patient to adapt to a neurogenic issue that is causing flaccid bladder. The patient with stress or urged urinary incontinence should be instructed to perform pelvic floor exercises, like Kegel exercises. The patient should be instructed to keep a voiding log. Wearing disposable brief is not dignified for a patient, and restricting fluids can lead to calculi. Urinary retention is confirmed using a bladder scan or by inserting a urinary catheter, if possible, and measuring the urine output. Renal scan, intravenous pylography or IVP, and MRI will provide information about the structure of the kidney and the vascular flow in the renal system, but they are not the tests of choice in determining urine retention. Benign prostatic hypertrophy is a common cause of urinary retention. Difficulty initiating and maintaining urine flow is often the presenting complaint in men with BPH. Neurogenic bladder is a urinary problem in which the bladder does not empty properly due to a neurological condition. Several muscles and nerves must work together for the bladder to hold urine until ready to empty it. Nerve messages go back and forth between the brain and the muscles that control bladder emptying. If these nerves are damaged by illness or injury, the muscles may not be able to tighten or relax at the right time. Stretch receptors transmit impulses to the spinal cord. Voiding reflex center located at the level of the second to fourth sacral vertebra, causing internal sphincters to relax. Need stimulation to void. If the time and the place are appropriate for urination, conscious portion of the brain relaxes and the external urethral sphincter muscles and urination takes place. Individuals with overactive bladder have little to no control voiding functions. Their bladders release urine spontaneously and frequently, though not completely. Their bladders become diminished because they are seldom filled to capacity. Because the bladders tend to retain small quantities of urine, their risk of urinary tract infections are significantly increased. Neurogenic underactive bladders have the opposite characteristics. Because there is damage to the neural system that informs the brain the bladder is full, the bladder continues to fill and may expand beyond the size and capacity of normal bladders. At a certain point, the pressure of urine in the bladder will overcome the sphincter muscles' ability to retain it, and urine will leak out. Like the overactive bladders, underactive bladders fail to empty completely and retain a small amount of residual urine. Continence bladder training, and a bladder training program may include the following. The patient postpones voiding, resists or inhibit the sensation of urgency, void according to a timetable rather than according to the urge to void. Voiding may be encouraged every 2 to 3 hours, except during sleep, and then every 4 to 6 hours. Practice deep, slow breathing until the urge diminishes or disappears, this inhibiting the urge to void sensation. Medicines that relax the bladder, oxybutynin or propanthenylene for overactive bladder. Medicines that make certain nerves more active, bethanechol for an underactive bladder. And medicines that treat infections, like antibiotics, if the bladder problems lead to an infection. Stress incontinence. This is loss of urine when exerting pressure. Stress on the bladder by coughing, sneezing, laughing, exercising, or lifting something heavy. Stress incontinence occurs when the sphincter muscles of the bladder is weakened. In women, physical changes resulting from pregnancy, childbirth, and menopause can cause stress incontinence. In men, removal of the prostate gland can lead to this type of incontinence. Urge incontinence. This is a sudden, intense urge to urinate, followed by an involuntary loss of urine. The bladder muscles contract and may give a warning of only a few seconds to a minute to reach a bathroom. with urge incontinence may need to urinate often, including throughout the night. Urge incontinence may be caused by urinary tract infection, bladder irritants, bowel problems, Parkinson's disease, Alzheimer's disease, stroke, injury, or nervous system damage associated with multiple sclerosis. If there's no known cause, urge incontinence is also called overactive bladder. Overflow incontinence. If frequently or constantly dribbling urine may have overflow incontinence, which is an inability to empty the bladder. Sometimes it may feel as if they never completely empty the bladder. When trying to urinate may produce only a weak stream of urine. This type of incontinence may occur in people with a damaged bladder, blocked urethra, or nerve damage from diabetes, and in men with prostate gland problems. Mixed incontinence. If experiencing symptoms of more than one type of urinary incontinence, such as stress incontinence and urge incontinence, then they may have a mixed incontinence. Functional incontinence. Many older adults, especially people in nursing homes, experience incontinence simply because of physical or mental impairment keeps them from making it to the toilet in time. For example, a person with severe arthritis may not be able to unbutton their pants quickly enough. This is called the functional incontinence. Gross total incontinence. This term is sometimes used to describe continuous leaking of urine day and night, or the periodic, uncontrollable leaking of large volumes of urine. In such cases, the bladder has no storage capacity. Some people have this type of incontinence because they were born with an anatomical defect. This type of incontinence can be caused by injuries to the spinal cord or urinary system, or by abnormal openings such as a fistula between the bladder and an adjacent structure such as the vagina. A competent vesicoureteral junction. Note how the increased intravesical pressure during voiding occludes the distal portion of the ureter, preventing the reflux. The ureter normally is attached to the bladder in an oblique direction, perforating the bladder muscle destrusor laterally and proceeding between the bladder mucosa and destrusor muscle, creating a flap-like mechanism that prevents reflux. Reflux occurs when the submucosal tunnel between the mucosa and the destrusor muscle is short or absent. Reflux usually is congenital, occurs in family, and affects approximately 1% of children.